Hello, hello, and welcome, friends. I'm so excited to be here with you tonight talking about a very requested topic. And actually, I kind of want to start out today by, really addressing the fact that most of the lives that I plan on doing, I'm going to be live here every week talking about myofunctional therapy in some way, shape, form, or capacity. And so if you have anything that you're like, burning inside, you just want to really know, and you want me to dive deep in on a live, throw it in the comments, okay? Because that's how these things happen. So this was definitely a requested one. How do you talk about myofunctional therapy in the dental practice? As a clinician, like, how do I even bring it up? People don't know what it is. It's an awkward conversation. I don't feel like I know enough to talk about it. I don't know exactly what resources to offer. No worries. We're going to knock down all of those walls and those barriers to you being able to really successfully have those conversations with your patients in the clinical dental setting. And I think the biggest thing is really just to be as confident as possible as you have all of these conversations. But we will work our way through this, and we'll do it together, and we'll be successful. So first, I want to start off by welcoming you all again. I know I already did, but welcome, welcome. This is going to be probably 45 minutes. So hang in there. I promise really good content, and we'll get into all of your nitty gritty. I will make sure I answer all questions before we end this live. I do want to say that tonight is talking about, again, another myofunctional therapy thing, and it's very much a passion of mine. And if it is not a passion of yours yet, or you're like, what is myofunctional therapy? Or who the heck are you? And why are you talking about it? And I just showed up live on your feed and you have no idea why. I'm Carice Laguerre. I am a registered dental hygienist, although I don't practice clinically anymore. I just do myofunctional therapy. I educate, I speak on it, I live it, breathe it, do it all the time. Myofunctional therapy is something that I have a lot of resources around and about. If you have not understood yet what myofunctional therapy is, this is probably not the lecture for you to start with. So I have a wonderful community on Facebook. It's the Myo community, where you can feel free to join, and all dental professionals are welcome. I don't care what you do in the dental office. You are welcome to come and learn. Everybody has to know and understand it if you're going to communicate with patients in a practice setting. If you plan on communicating with patients outside of a practice setting for an independent myofunctional therapy practice, you can glean some information from here too. But if you're looking to learn basics like introductory, what myofunctional therapy is, join the group. It's the Myo community on Facebook or wherever you may be finding me. I am streaming live right now on YouTube as well. Feel free to subscribe to my YouTube channel. I am at the Myospot, TheMyospot, and you can keep up and watch all of the previous, 7 lives that we've done. Okay, so jumping in, myofunctional therapy is critical for all dental people, all dental clinicians to be able to know, understand, and communicate. And then from there, you're going to be able to really amplify and help people in very dynamic ways. This is a 100-year-old specialty that has been around since the early 20th century. At that point in time, when it was discovered, it was all about facial aesthetics. And somewhere along the way, the dental industry kind of lost its grasp on the importance of the facial form, function, airway, and that sort of thing, and kind of let its way into just cosmetics and getting everything into alignment. And so now we're kind of backtracking, and I am so happy that the field is backtracking, because we need a little bit of innovation. Can't keep doing the same old and expect new results. So very clearly it is time for a change, and we're getting that shift in the industry. And so what's going to happen now? We're going to be talking myofunctional therapy, and there's going to be more practices where you're hearing these words, you're hearing these things being said. So to quote the great philosopher Notorious B.I.G., if you don't know, now you know. And that's probably going to be the theme of tonight, because a lot of what you will be doing is informing and educating patients and getting them to the point where if they didn't know what myofunctional therapy was and they weren't excited about it, guess what? They're about to be. Okay. So if you're not already talking about myofunctional therapy, it is like the number one most holistic non-surgical approach for you to be able to restore mouth breathing where there is no physiological block in the nasal passages, but to restore mouth breathing. Mouth breathing, we know 100% contributes to periodontal disease in a number of ways. It is very much the highest biomechanical contributor to periodontal disease, vertical bony defects, anaerobic, opportunistic bacteria, creating spaces for that. Gut imbalance, there's a lot of ways. Leaky gut, we got a lot of people who have diarrhea or a mix on the other end with constipation who struggle with a lot of these issues. A lot of the gut imbalance, it starts here. It starts all the way up in the mouth at the top of the digestive chain. Tonsil stones, for the exact same reason, opportunistic bacteria, everything sort of sits and settles, and then it doesn't get to move out. It creates more permeable space in the tonsils. It changes the content of our saliva, our salivary glands. We are unable to maintain a healthy balance of bacteria where we have more of the good bacteria than the bad. A lot of that is because of the dry mouth. So dry mouth winds up happening as a result of mouth breathing too for some. TMJ degradation. We don't talk about it enough. A lot of what we talk about when we talk about TMJ is how the muscles aren't really working well and so forth. But when you're mouth breathing, you're actually altering the way that your jaw is sitting. Like you're altering the way that it is, that freeway space, when it gets expanded, you're altering that angle. So the angle of the condyle eventually changes. That changes the way that the TM joint, the temporomandibular joint, is able to sit within itself, which is then going to contribute to it not riding on the joint appropriately, and it's going to create structural wear and tear. And then that's how we get a lot of the issues that we can't necessarily resolve by eliminating the mouth breathing, but we can collaboratively work together with a provider who's going to do something structurally and help to achieve optimal outcomes for that. Malocclusion, where your tongue rests matters. Need I say more? Cardiac issues, reproductive issues. The list could literally go on. There are a lot of different ways that it contributes to nutritional imbalance. You're going to not be able to absorb nutrients the same way. Higher blood pressure, stroke increase, sleep issues. There's a number of things that mouth breathing contributes to that are entirely super detrimental. And I really wish that mouth breathing, we could stick a label on everybody when we see them and their mouth breathing, stick one of those smoking labels on there. So the labels that are on the cigarette packages, just to let them know that, look, you're putting yourself at a high risk for a lot of different things. So if you aren't talking about myofunctional therapy in your practice now, why? Like, what are you waiting for? I can't imagine that you have no patients in your office that are mouth breathing. You have no patients at all that are experiencing any of the things that were listed there, in conjunction with the fact that you've witnessed them mouth breathing in your office. You've let them come and go, probably for years, decades for some who've been practicing and seeing the same patients over and over. Maybe now you're treating their children. Their children have been mouth breathers. And this whole time, nobody's ever talked to them about how mouth breathing is really contributing to the degradation of their systemic and overall health and wellness. So what are you waiting for? You're waiting for me to help you understand how you can communicate it? I hope not. I hope you've already tried to communicate it at least a little bit before now. If you have not, welcome. There's no better time than today to start to make the changes that we need to make and that we know we need to make in our lives, because as clinicians, dental clinicians, this is all in our wheelhouse, okay? So don't let anybody tell you it's not your scope, because every time you ask a patient to open their mouth, and I am certain you tell multiple patients multiple times to open their mouths, you are deep into the airway already. Okay, when you ask them to open big and you take a look at their palate, you're getting a look at the floor of the nose. You're getting a look at the floor and the front of the nasopharyngeal space. You're really getting a window into it because that floor of the mouth, floor of the nose passage, when it is part of a vaulted or a narrow palate, you know that there's not much space going up there for those nostrils to really be able to facilitate enough respiration. When they open big and you look back, can you see their throat? Can you see their throat? There's a whole bunch of things I want us to say. Can you see their fauces and their tonsillar pillars? Are you able to see? No. Can you see their throat? Can you see their uvula? Do you see it very prominently? Can you view the oropharyngeal space? If you can't, that's a great indicator of what might be going on behind there. It's definitely a good indicator of a conversation that you need to have with your patients, and we'll get to that in a little bit. Every time you look at the lower arch, the mandible, you're looking at the jaw for your patients, you are absolutely positively, without a doubt, looking at the anterior and lateral borders of their respiratory tract. Okay, you're looking at that. Anytime they advance that mandible, guess what's happening? You ask them to shift their teeth forward, they're opening up their airway just a little bit because that border is now providing a little bit more space. So you're already looking at airways, whether or not you knew that you were. And every time you've been in your patient's mouth, you've kind of been already looking at their airway, and you should have a little bit of an image of what's going on based on your knowledge wherever you're at with myofunctional therapy. So this is absolutely within your scope. This is absolutely something that you should be talking about with your patients, if for nothing else than to do a very comprehensive overall intraoral, extraoral exam, because that's what we're about. We're comprehensive clinicians, right? So when we're looking for orofacial myofunctional disorders, and you may be like, what's an orofacial myofunctional disorder? Lucky you are in for a treat. We're going to be able to look for some, and I'm going to give you a wonderful screening acronym that you can use and a wonderful little screening tool that you can use. So get ready to use your screenshot, or, if you're taking notes, hopefully you're taking notes. You'll take some notes in just a second. But an OMD, commonly it is going to be abbreviated in a lot of the social media groups. You'll see OMDs all the time. It stands for orofacial myofunctional disorder, and it's just an inability to utilize proper oral or facial muscle function. So it's really dysfunction, okay, within that orofacial region. It's typically characterized by over or underutilization of muscles when breathing, masticating, and or swallowing. It sounds very complex. It's really not. We understand as clinicians, especially the actual clinicians, the doctors and the hygienists, we've got so much going on with our tactile senses. We can feel when somebody has very tight musculature. We know because we're there trying to fulcrum, trying to get our hands in places and trying to feel around and figure out what's going on. We know when there's an abnormality before a lot of other professionals do. And so we are definitely key for being able to understand when something is abnormal. In the same way that you're looking for like oral cancer, whenever you're screening, you're looking for something that is unusual, something that you don't typically see. It's going to be just like that here. You're looking for something that is out of the ordinary. And so I've got a wonderful screener for you, Brooms. Brooms, Brooms. It's like a sweeping generalization. And I like to think that that's my cute little way of putting together words. But Brooms is a sweeping generalization where you're really going to be able to, at a glance, and oftentimes in significantly less than a minute, okay? And that was the whole purpose of this screener being created. There are other screeners and other things out there that want you to take measurements, or want you to do this, or want you to do that. I have been a clinical dental hygienist for, I don't even remember how long I've been doing it. I've been out of it for some years now, but I was a clinical dental hygienist and I never had time. And I wish somebody would come into my office and tell me that I need to start looking for something new and I need to fill out some sheet and that I need to do this, that, and the next thing. No, honey. I don't have time for any of that. Nobody has time for any of that. I barely have time to type in these notes. Like sometimes I don't get to leave on time or I don't get a full lunch. So no, I'm not doing anything extra. So brooms kind of came about because hygienists understand hygienists. We understand that we don't have time for any nonsense, anything extra. So this is like a quick, less than a minute. You already know half the answers, probably before the patients get into the chairs. This is going to be your help. Okay. And this is not some fly by night thing. This has been written about several times. It's been published between Dental Sleep Practice Magazine, Spear, RDH Magazine. So it's a thing. Okay. Don't dismiss it. It's absolutely a thing. So let's go through the broom screener, okay? The B is for bruxism. Do you know and can you easily identify when your patient is a bruxer? I really hope everybody's like, yes. I mean, you could throw it in the chat. There's a little delay here, so I'm certain that you guys 10 seconds behind, you're like very much like, yes, we can identify. Great, awesome. Okay, so you can identify it within a second. You know what it looks like. You know how you can tell occlusal wear, attrition, so forth. You're going to be able to say yes or no to that, okay? Respiration. Can you hear them breathing? Breathing at its core is not to be heard, okay? Breathing is inaudible when you have healthy respiration. If you can hear your patient breathing in your chair, red flag, all the red flags, okay? There is this guy on TikTok, super random rant that I'm about to go on right now. Guy on TikTok, if anybody's on TikTok, and I hope he's on Instagram too, but he actually runs around with this really large red flag. And that's what I imagine when I hear somebody who is breathing. I'm like, you've got the biggest of red flags, okay? So audible, yes or no. If it's not, that's within normal limits. So you just get that within normal limits that you'll check off there. Are they orally defensive? Now, what is orally defensive? Can somebody give me a really good description of how they or what they imagine when they hear orally defensive? I'm going to tell you who I think of. When I am imagining for myself somebody that is orally defensive, here's what they're doing. I'm going in, I'm trying to fulcrum, I'm trying to just scale. All I want to do for my life's work is to scale the lower anteriors. That's all I want to do. So I'm in there, I'm trying to fulcrum, and there's this lip that just covers up everything. They suddenly get super tight, and now my finger has to fight for its life to be able to stay on there as a fulcrum, and I can't even think about pressing on my rheostat so that I could get my cavitron going. I can't think about it in any capacity because it's gone. Like they're so tight, so defensive. They don't want me in there. Tongues all over the place. Somebody said that, tongue wrestling my mirror. Yes, tongues all over the place. They are just in a hot mess express as you're just trying to clean them. And they're not doing it intentionally. They don't want to do it. Okay. We know who those people are. We dread them. We see them in the schedule. We've got a note that says something in there. Okay. We understand who those people are. You know who they are. That is a second. I don't need to think twice about that. And I will happily write that on any sort of documentation anywhere that I can. So orally defensive, yes or no. You're going to give yes or no. Open mouth posture, as they are just sitting in your chair. You can probably observe this as you go to grab them from the waiting area if you do grab them. If you're not grabbing them from the waiting area, if you're doing like assisted hygiene or you're a dentist and somebody else is seating the patient for you, when you walk into the room, as you are chatting with them, getting your quick like, hey, how's everything going, any changes, whatever, observe what is their oral posture. Is the mouth open as they're just sitting there waiting to talk to you? Because that's going to be something that is also another red flag, probably a smaller red flag than the respiration one, but definitely a red flag. Maxillary transverse width, their palate size. Do they have a narrow palate? I don't need you to measure. As a dental clinician, you can look at a person and probably tell me whether or not they have a narrow palate. So I don't care about your measurement of their palate. I don't need you to go grab a tool or add something extra to your tray. Is it a narrow palate? Does it have a big, broad U shape? all the teeth look like they fit in there perfectly, like everything is wonderful? Or is it more of like a V or an omega arch shape? Like, what does it look like? Is it narrow? If it's narrow, then affirmative. Otherwise, it's within normal limits. Strained mentalis. Strained mentalis, sometimes you're going to look at this muscle down here. Now, this one isn't my favorite one, but it's on here. Strained mentalis, sometimes you'll look at this muscle here and it could be stippled like an orange peel. So it'll be super tight and you feel just the muscle pulls against your mirror sometimes when you try to get down there and you're trying to look at maybe the anteriors of the you're trying to look at the buccal surface, I should say, or the facial surface of the lower anteriors. You're trying to look at 23, 24. You just want to look and see what's down there, and you get this pullback on this mentalis muscle that just will not let you live. Strain mentalis, yes or no? Just two. I don't need, 3, 4, 5, two or more in the affirmative column. Okay. So the yes, audible, yes, narrow, or yes, two or more is time to talk about myofunctional therapy, refer to myofunctional therapy, or drop them on a wait and see. Okay. If they've got just one, let them live. If they've got all of them, please right away. That's like an emergency myo patient. Hopefully you have a myofunctional therapist in your office or somebody nearby that they could just like run over to because they need it right now. Okay. So 2 or more affirmative column. If you weren't writing that down, don't worry. This will live as a recording wherever you are, LinkedIn, YouTube, or Facebook. Okay. You have other opportunities upon which you can determine whether or not there are OMDs. So let's say you're like, I don't like the brooms. I don't want to have to memorize the brooms. I don't need that stress in my life. Okay, awesome. You're going to ask them about medical history anyway. Why not determine what are the high risk things that you need to know that could correlate with mouth breathing or orofacial myofunctional disorders like obstructive sleep apnea. Do they have a history of obstructive sleep apnea? Do they have a history of snoring? Do they have a history of high blood pressure? Do they have a history that correlates with digestive issues, GERD, gastroenterological reflux? Do they have issues that are associated in the medical history? Extraoral exam, when you're looking at them and you're doing your extraoral exam, I hope people are still doing those. I don't know if people are still doing those, but those extraoral exams where you're looking and sometimes you're feeling the musculature. Are you feeling anything abnormal? When you're looking, you want to look to see, do they have narrow nostrils? That's going to give you a kind of an idea of what you'll see when you go in there and you're looking at the palate. Do they have long facial growth? Do they have vertical maxillary excess? That's a gummy smile. They smile at you while you're doing this extraoral examination. What are you determining that is not within normal limits in your extraoral exam? Your intraoral exam, now you get in the mouth. Can you visualize their uvula, or can you see the back of their throat? Can you visualize the tonsils? I don't need you to grade them. I don't need you to grade the uvula. I don't need you to sit down and do anything extra that you don't want to do, but can you see them? If you can't see them, red flag. Okay. Can't see them. There's crowding in the mouth. Red flag. If you understand what a tongue tie is, and I'm going to say that with the biggest grain of salt because I don't care what it looks like. It's all about function, okay? And you guys can fight me about that later, but I don't care what it looks like. If you understand what a tongue tie is, you can put that into your checklist of categories in your intraoral exam. When you're looking for tethered oral tissues, you have to understand what these things are because I don't care what it looks like. It's all about function. So you can look at 10,000 of them and probably some of them most likely are not in any way, shape, or form inhibiting function. But we'll save that for another soapbox rant that I get to do later on. And then exploratory conversations. Exploratory conversations are always those chats that you're having with people afterwards. So I like to throw in there easily, very smoothly, how's your sleep? Yeah, sleep's fine. Okay, great. That's a wonderful response that gives me zero information that I can use in any way, shape, or form. So, how's your sleep? If you had to give it a grade on a scale of 1 to 5, where 5 is like every night you get fantastic sleep, you wake up every morning, you feel amazing, you're ready to go throughout the day, and 1 is you can't remember the last time you had a great night of sleep. Every night of sleep is pretty tough, and you really just can't get yourself to stay asleep or get to sleep, or you struggle in some way. 1 to 5, where would you put yourself? And then they're going to give us a score. Why? Why did you give us that score? Like, what was that? Once they start to justify it, then they'll give you things that you didn't even expect. Okay. So every morning I wake up with drool. Were you going to ask them about drool ever? No. No, you weren't going to ask them about drool ever, probably, but they're going to give you that stuff, right? So every night I wake up and there's like drool on my pillow, and it is just the most disturbing thing, and it's disgusting. And like, my girlfriend broke up with me last week because she was just tired of it. She said that I snored really loud, but like, I feel fine. I get through sleep. So I don't know, maybe I'll give it a 4. Okay. I like that. You've given me a lot of information. Why are you drooling on yourself at night? You're probably sleeping with your mouth open, right? What's going on with the snoring? Snoring's unusual. We don't want snoring to be occurring, because snoring is the sound of air meeting resistance as it's going through your upper respiratory tract. These are conversation points. I've now got information that if I just stuck with, how's your sleep, I would have never gotten. Okay. So you have opportunities. I genuinely and wholeheartedly believe that the easiest way, the path of least resistance, is probably to use some type of screening. There's a lot of different screeners out there, so you don't have to use brooms if you don't like brooms, or if it's too simple for you and you prefer to complicate things. Do whatever you got to do, but make sure you're doing some form of screening, okay? Some form of screening. Then after that, start the conversation. Just start the conversation. And as you're seeing things, when you see something, say something. That's what I like to do. It gets people thinking. It really does get them kind of in their mind wondering what's going on. Once you start to talk about certain things, like imagine you're going in there, let's say it's the examination, and you're shouting out all these letters. So letters and numbers, MOD, 18, class 5, number 9. You're shouting out all these things. The patient has no idea what these numbers are, or what these letters mean, or what's happening, right? So then they come out of it like, okay, am I okay? Like, what's happening? Is everything all right? What are we going to do? Like, am I dying, doc? No, you're not in any way, shape, or form. But we kind of already got the conversation going. So, I noticed that your palate's a little narrow. We've actually been learning a lot more in the practice, and I've actually invested myself in a lot of additional research. So in the past, I don't know, however long you've been studying this stuff, but in the past 10 years, I've been reading and learning a significant amount more, over 100 hours of CE. And in all of that time, I've started to really implement now that there are some issues here that we would like to address now. Sometimes you might want to address it now, or we want to watch and see. I want to take a better note of what's going on with you. How are you feeling? I'm going to ask you more questions next time you come. I'm going to take note of what I'm seeing now, and we're going to make sure that you're able to, function appropriately, and that your oral health is my utmost priority. Your oral health is tied in very closely with your overall health. I mean, I think we've all very much gotten the full grasp of the oral systemic connection. So just start explaining these things. Just start the conversation. Start dropping the little nuggets. I got a little comment here. This stuff can change a person's life. That is very, very true. Look at that. Let me put you up here. This stuff can change a person's life. And this person's child has been helped by identifying the sleep disorder at age 5. That whole wish it was earlier thing, that is such like a pain point for me. And I speak to a lot of parents, and I'm actually going to talk to you guys about this in just a second. But I speak to a lot of parents, and I think a lot of parents, we hold a lot of guilt because we wish we knew things earlier. that we didn't know. And you can never, ever, ever, ever go back and make those changes. So it doesn't make sense to beat yourself up for these things. And there's always going to be regrets in life, right? There's always going to be something that you didn't get an opportunity to do. And this is an entirely different soapbox that I'm on right now. So just roll with me for a second. There's always going to be things that you didn't get to do. So imagine you had a choice that there is, a concert or there's a fair, and you decide you can't do both. You can only do one. They completely overlap. And you decide that you're going to take the family to the fair instead of going to the concert. You will never, ever know what your day or night or whatever could have been like had you gone to the concert instead. You won't get to know. You don't get those moments back. You'll never get that time back if the concert comes around another day. Like, it's not the same concert. It's not the same people. It's not the same energy or venue. You'll never know, right? So how long can you beat yourself up for deciding to go to the fair? You can't. You really can't. So it doesn't matter what it is. There's always some opportunity or something that's always going to be, oh, I missed out, or I'll never really know. You won't be able to close the loop on that. It's okay. It's absolutely okay. As a mother of 4, I really didn't learn about most of this stuff until I had my 4th. And even when I had my 4th, I still didn't really understand because, again, at that time, it's my 4th. So like, I've been through this 3 times. My kid's going to be fine if I give him a pacifier. We're going to be fine if we have a sippy cup. Like, I'm totally fine. I get it. This kid's going to be all right. And the kid is not all right. We're actually very expensively working our way through all of those issues that I caused and contributed to. And it's costing me thousands of dollars now in orthodontics and releases and all sorts of things, and body work and whatever. But that's neither here nor there. It's important to start the combo, just like our commenter said. It is important because it does change and impact the trajectory of people's lives, okay? But I will say that when you are starting this conversation, we are in a world where we are bombarded with ads. Absolutely bombarded. It used to be a day and time where we would remember our Super Bowl ads, or we would remember like the most, creative or exciting Super Bowl ad that we had seen. And we might remember them for months to come. I can't tell you, outside of the bizarreness that was Kanye West, his ad, I can't tell you what some of those other ones were. You know why? Because I've been marketed to intensely, significantly since. It's like when you talk about something next to your phone and you know it's listening, because when you go and you start scrolling again, or you get on a search engine, the very first thing that pops up is whatever it was that you were just talking about. And you're like, what is this madness that is Big Brother? So we are always being bombarded with things. People want us to buy stuff. If nothing has ever been more clear, people want us to buy stuff. So be honest, all right? If your goal for them is to help them and to get them to a myofunctional therapist because, you've experienced this on your own, and these were the detriments of what happened in your story and your journey, please be as honest as possible. Be open. There's nothing people value more. We crave honesty and authenticity. We want that because we are deprived of it so much. Everybody's paid for something, right? It's a paid ad. We have influencers who tell you that they love this product, but how much is that product paying them to say that? You know what I'm saying? So there's a lot of disingenuous communications that we have that are in front of us all of the time. And we really, really, really want honesty. So be honest in a lot of your conversations. I promise it's going to work out in your favor, because the less that you do, the better off we all are. Okay. So don't go trying to make stuff up or sounding all fancy schmancy or giving them all these words, or, oh, I've noticed that you've got several oral facial myofunctional disorders. I don't care about that, honestly. And particularly because of my journey, I can understand more from a patient's perspective who does not care about whatever it is that you're trying to talk about on a scientific level. I started to know and understand this stuff, like I said, with my 4 children. When I had my 4th, I was a parent. I understand everything is fine. Like, nothing's wrong with my children. What are you saying? Like, And there was a lot of stuff wrong with my children, a lot of stuff wrong with my children. But I don't want you to tell me that, right? I don't want you to tell me that. I want to discover it on my own. And I would probably have discovered it easier and better if people stopped talking to me about it on a scientific level and just got really real with me. And it actually took Paula Fabi being really real with me, looking at my daughter, and she was with us. We had 2 hours blocked out for an evaluation. She spent maybe 10 minutes with my daughter, and she was like, she can't breathe. She needs to go. She can't breathe. She doesn't need to be here. We took the CBCT after seeing Paula, and it turns out she really couldn't breathe. We went to Dr. Stephen Park after she saw Paula, and it turns out she really couldn't breathe. She only had 10% of her nose that she could use. It was 100% occluded in one nostril, 10% she had available in the other nostril, with the adenoids and the deviated septum all kind of creating a big cluster of stuff. So I didn't need people to tell me like, oh, her teeth and her canines, they're impacted, whatever. I could do orthodontics later for that, like whatever. But when you tell me she can't breathe, and Paula Fabi looked at her for just a hot second, like, and said she can't breathe with no x-rays. And Stephen Park had to look at her with a scope. And Paula Fabi knew that she couldn't breathe. And that's all I needed. That is all I needed. You tell me my child can't breathe. All of a sudden now I'm holding myself fully accountable for the fact that I didn't know, and that this child has been struggling with only 10% of her nose for her 7 years of life, and nobody knew. And so it's incredibly important that you start having these conversations and have them really, really raw and honest. So as you're developing your talk, think about what brought you to Myo. What brought you here? Like, what got you interested? So I know for that one Facebook user, because it doesn't give access to people's names. I know for your one Facebook user, their child has been helped. They wish they knew sooner, when their child, was 3, was 2, was 1, was in utero. I would talk about this stuff. What happens if I'm talking to an adult? What happens if your 5-year-old wasn't helped at all? What happens if your 5-year-old turns into the dysfunctional adult? Because that's what I'm now talking to adults about. It's like, if I never did anything about the fact that my daughter couldn't breathe, if I wasn't aware about the fact that she couldn't breathe, she would have developed into da-da-da-da-da. And that would have crushed me. That would have absolutely crushed me. It probably would have crippled her with all sort of medical issues, and then, debt, because the medical system, that's another soapbox for another time. But that would have been an entirely different conversation, an entirely different world. And at the end of the day, I would have felt deeply responsible for that if I see her as an adult and there was something I could have done when she was younger. And that dysfunction, we know it just tends to compound. So if you're talking to adults all day and your main connection is children, because that's my connection to it, my connection is through my children and their experience, I connect on that level and my deepest subconscious fears. And then how can I, being as vulnerable and honest as possible with my patients, to the point that I feel comfortable with, and I don't care. I'll share as much of my story as possible. So you share what you feel comfortable with and connect to them. That rawness, that honesty, there's nothing like that. We don't get that authenticity. You've got me roped in. At that point, I'm like, yeah, I'm leaning in. I want to listen to more of what it is that you have to say. And if it takes you time to put that together, that's okay. If it takes you time and you have to sit down and you have to rehearse and you have to say, okay, I'm going to look in this mirror and I'm going to tell myself this story again, and I'm going to try not to cry. And this slide actually is out of a lecture that I have in Myo Mentality, which is a membership platform I have with a bunch of different lectures. But in that lecture, I wind up crying, talking about my story and my journey with my children and how raw and real that gets for me every single time I go back there. So if you have to rehearse, because these are your deep subconscious things. I felt deep in my soul so much shame for being a bad mother, for not understanding sooner that she couldn't breathe, for not having whatever magic eyes, which I know are now Myo eyes, but for not having whatever magic eyes Paula Fabi had when she looked at my kid and just knew what was wrong. I felt deeply ashamed. And in that shame, I owned it as I failed her as a mother. And since I failed her as a mother, I'm not going to fail these patients. I'm not going to fail not one of them. They're all going to know, they're all going to understand. And if they hear my pain and they decide they don't want to do anything, that's well within their right. It's absolutely well within their right. But we have to, take ownership for what we see, we should say. But you have to have these conversations differently than you would hold a conversation about caries, because your conversation in the dental chair about caries has intent and it has purpose, and there's a reason that the patient is there. They kind of want to know. They want their cleaning and they want to know, are their teeth healthy? Did they do a good job? Did they floss enough? Did they brush enough? Did they prevent the cavities? So they're there for that. You can have a conversation that's really loosey-goosey about that. No, nobody cares about that. But if you're going to get deeper, if you're going to dive deeper, like with Myo, you have to dive deeper. Nobody cares about proper oral resting posture. Nobody cares. People are not mewing for proper oral resting posture. They're mewing for a defined jawline. There's a difference. Okay. Nobody cares about that. You got to get deep into what people actually care about. We care about connection. And we care about pain. We want to reduce the amount of friction or pain that's going to be in our lives. And so make sure that as you're having these talks, you get raw, you get real, you get honest, you can rehearse it, but don't make it too rehearsed, okay? Maintain your confidence in who you are. You are an expert in the topic. Your patient knows diddly squat. You know everything. Your patient knows nothing. You know everything. You're the expert. You don't have to know everything. I don't know everything. Like, nobody knows everything, but you get what I'm saying. As far as they're concerned, you know everything. So own that. You're the expert. Don't be shy to talk about it. Don't feel like it's weird to talk about. They don't understand what it is. They absolutely understand being a parent. They absolutely understand their own health and their daily struggles and the inability to sleep. They absolutely understand those things. And once they understand those things, then it's easy to start that conversation by just connecting with another human. We're craving connection these days because we're also disconnected, where we're like a screen away from each other. And we don't want that. Okay. Make sure you're using all of this at the right time. So while their mouth's fully open and they're all the way back supine in the chair, and maybe you've got a bunch of water that you're rinsing them out and you've got the suction going, that's not a good time for your deep, raw, personal conversation. When they're sitting up and you're sitting and you could talk to them face to face, eye to eye, level to level, that's a really great time to go deep. It's a really great time to connect. That is a perfect time for you guys to really have those conversations. Okay. Heavy stuff. You guys still with me? Everybody's okay? Give me a yes in the comments. Let me know if you're all right. All right. I know. Hopefully nobody else is crying. Don't cry. All right. Have your resources ready. There's nothing that is more inconvenient than being told something, and then I go and I scroll on TikTok, and then I learn a new random fact about cows that I didn't know before, and I've forgotten almost everything that you just said. It's going to happen. It's bound to happen. So have some sort of resources ready. That way the patients can understand what it is that they're going through. Now, I like to have something that they can have in their hand, because the very first thing, what is the very first thing that everybody does when you learn about something new? The first thing I would do, and I think 89% of the population, mostly because that's what research says, but 89% of the population is going to Google it. It's a verb. They're going to go and they're going to type it in. So whatever resources you have, make sure you're guiding them to some appropriate ones and not the ones that we don't want them reading, right? We know that there is a lot of information on the internet and they can fall down a hole of confirmation bias. So confirmation bias is absolutely a very real thing. If you Google myofunctional therapy scam, you're going to find things that are going to be geared towards that. You're going to find, myofunctional therapy money pit. You're going to find things that are geared towards that. Now, different ads are going to say, like, you don't need myo, you need mewing. You don't need myo, you need this. You don't need myo, you need that. And it's going to send them down a rabbit hole. So have them get good resources that you actually want them to have. Okay. So you have a website. If you don't have a website, find a website that you really, really love that has a lot of good information on it. Send them to that website resource page or compile resources of your own. Send them a link. Create a bit.ly link to a Google Drive. That's all you need. Have all the research there. Yay. That's perfect. And it's free. Okay. So you have a list of books that you love. Now, here's why I typically don't recommend books. One, not a lot of people are reading. I mean, I don't know. Maybe you guys know all the people that are reading, but absolutely none of the people that I've recommended books to have actually gone, purchased the book, and then read it. A lot of them have purchased the book, skimmed it, but not many have read it, particularly because everything is so easy access nowadays. If it's not on Audible, and some of this stuff is not on Audible, if it's not on Audible, they're not going to, consume the content. And if there is no like abbreviated version, so you think Cliff Notes are dead, they're not. Cliff Notes are just YouTube now. Okay. There is a short version of everything where everything has been abbreviated. So I don't typically do book lists. I would give them something like a link with a playlist of all the books that have been reviewed, or like what the key takeaways from those books are. And then from there, let them understand enough information to whether or not they would like to invest in getting the book and actually reading it. But if you have a book list, assemble your book list. There's a practice I used to work in. There had all the books all together, like in a nice little it wasn't a shelf, but it was on one of the ops. It was an op that we weren't using, whatever. And so it'd be like, hey, just come with your phone, take a picture, all of the side covers of the books. And then there you go. All the books are there. Yay. Wonderful. It is a fantastic way to get your patients kind of thinking and to get them on some good resources. And then, is there a social account that you know of or that you own that has a lot of educational information? I highly recommend that you have your own resources. Everybody loves a good freebie. Opt-ins are the thing, and email lists are power. Okay. Absolute power. Having the ability to have people's emails and owning that information is so much more valuable than like a social media page that you can get blocked and banned, and like that account can get hacked or you can lose it. And then you've lost all your followers, right? They're all gone. You can't get back that same assembly of followers exactly the way that it was when you start up a new page. You're starting from zero. But if you have all their email addresses, you're always in contact with them, right? You own that information. Information is power. Never forget that, guys. That is very, very key. Make sure that you are, providing some method of educating them if you are not going to directly be the person to educate them. So if you are not able to get them to book and to schedule with you, or you're getting them with a local myofunctional therapist and you're not able to make sure that that appointment happens, be in charge of how they get their resources effectively afterwards. Okay. So what are you going to do? Start slow. Please start slow. Like, pick really, really obvious cases, severe cases of like tongue thrust where it's so obvious. Like, you can't miss the fact that this person has a tongue thrust. That's the person I want to start talking to about myofunctional therapy, not the person with like, some mild crowding and who feels fine, who tells me that their sleep is a 5 and their medical history doesn't indicate anything to me out of the normal, but I feel like they have OMDs because the broom screener says so. That's not your first people to talk about myofunctional therapy with. Those are actually going to be your uphill people. You don't want to do that. You want to start with like the nice level playing ground. So work on those very obvious cases. Start thinking about new medical history questions and or exploratory questions that you can ask and start to gauge and have better conversations with your patients. And then you're going to have all of those people who are not your severe or super obvious cases, who are like the people that you want to kind of wait and watch, wait and see. wait and see doesn't have to be a bad thing, but sometimes we feel like, oh no, it's so detrimental because they're not coming back for another 3 months. They're not coming back for another 6 months. And I know that they have a problem, but I'm just like watching it. This is mind blowing. You told me if I see something, say something. Absolutely. If you see something, say something. But like, they can wait. Okay. It's not going to kill them. They're not going to be fatally detrimented if they're not the overt obvious case. Okay. They can be told in very simple, easy to understand, plain English. We are learning more. We are researching more. I want you to do research with us. I want you to really go into these resources. I have this list here. There's a lot of great education here. If you're seeing that some of this stuff really resonates with you or relates to you, please call us before your next recall. But I think that honestly, you can wait till your next recall and we're going to have deeper conversations. I'm learning so much more because I want to help people like you to thrive. And so I'm going to put it here all in my notes. I'm going to take very detailed notes. Trust me, Mr. Jones, nobody's taken better notes of anything ever than I do when I find these things in patients. And so because you have this narrow palate and because your rugae is very prominent and you have a very long face, I wouldn't say that long face thing, but because you have, long craniofacial development, I'm going to put some notes here and let's have better and more conversations about this next time you come. Awesome. Yay. Mr. Jones is happy. You're happy. Everybody is happy. And we just wait and see. And then the people you really need to sit down and talk to and have those heart and hearts with, because honestly, how emotionally draining is it to have those heart and hearts with every single patient? I can't do it. I could do that a couple of times during the day, but I can't do it every single minute of every single day. So it becomes very draining. Have those with the important people who need those conversations, who are like the immediate, like we're getting on, like, wow, your obstructive sleep apnea might be moving more out of that moderate towards that severe if I wait to have this conversation with you. Let's have this conversation now and get really deep, get really raw, get really, personal. Okay, if you are not a myofunctional therapist yet, or you don't feel confident, actually doing the myofunctional therapy, leave it to the experts. Okay, leave it to the experts. There are plenty of myofunctional therapists. I lied, there's not, but there are myofunctional therapists that you can find. I think the number of us that practice well and practice confidently well enough that we could take on cases that are like big to do cases, that number is very small, very few, but there are a lot of myofunctional therapists that are out there. Okay, you know what I mean. You could check directories. You could go on social media. I really think the very, very, very best place is to actually just Google it, because directories in most cases are directly associated with some type of membership or some type of association. And you don't need that kind of, wall or barrier between you and your patient being able to get the help that they need. And sometimes they're difficult to navigate. I'll be the first one to say that the IAH's, directory is very difficult to navigate, but it's there and it is a thing. Google, put myofunctional therapist near me, reach out. I have never met a myofunctional therapist that did not want to talk about myofunctional therapy. So if you have a lot of questions, if you're trying to figure out how you would refer to them, guess what they're willing to do? Have those conversations with you. Okay. So have them, start having those conversations, look for them, speak to them, get more information and learn and grow in that way. Or there may or may not be a myofunctional therapist that you may see in your bathroom mirror almost every day. It could be you. You could be the myofunctional therapist. If that's something that you're interested in and you're like, well, what's my best path forward? Like, how am I supposed to navigate this? There are so many courses, so many things. Honestly, if I'm going to be the most honest I've ever been, you need to start talking to the teachers. But before you do that, talk to yourself first, understand what it is that you want out of the myofunctional therapy program. What is it that you absolutely positively by the end of this course, I need to know, I need to be able to do, and I need to feel so that I can thrive and understand wholly that my investment was made 100% without error. Once you understand that, you can have and assemble questions that you know are going to lean you to who is the right instructor for you, who is the right person for you to take a course with. And I'm entirely super extra biased. I'm going to talk to you about myopathway for a second. Thank you for hanging in with me. If you've already taken a course, please listen to this myopathway spiel. That way you can tell all your friends what's out there, okay? Myopathway is a 28 CE course. There are 26 hours of full lectures on all sorts of things. So it's all the basic stuff, like what is myofunctional therapy, the foundations of such, all the research, the exercises, the forms, the resources, yada, 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 right? We could talk about that till the cows go blue, come home, or go blue, or whatever it is. We could talk about that for however long, but the real deal here is that I go above and beyond that, because I don't think anybody should just stop at myofunctional therapy, mostly because nobody that's practicing myofunctional therapy effectively or efficiently, remember I told you that number is few, does just myofunctional therapy. We're all doing some form of breath work or rhythmic movement, or we're helping with cranial nerves. We're doing all sorts of stuff, working with appliances and special cases and doing all that stuff. So I throw all that stuff in there. How you work with CBCTs, understanding them, deeply understanding anatomy, all that stuff that I was talking about with the TMJ and how that alters the structural cranial nerves. Dental sleep medicine is DSM. How do you work with appliances, special cases, such as those who have genetic components? If you've never worked with a person who is absolutely genetically destined to have oral surgery, this is absolutely a lecture for you, but also the cosmetic cases, yada, yada. So we go through a lot of different stuff, 26 hours of stuff so that you feel super confident. You have 6 months of live weekly access and interaction with me. So every week you could talk to me for 6 months straight. That is longer than any other course available. Oh, and you have lifetime access to that 26 hours of information. And anytime it gets updated, guess what? You now have the updated lecture. It is eligible for certification. COMP would be the letters, and I do 2 days at no additional cost. So in the cost of the course, 2 days of on-site mentorship, meaning I come to you. You don't pay me any extra. You tell me where you are, where you're working, or wherever you want to be, or however you want to do this. And I come to you for 8 hours whenever you're ready for 2 days. So that's 16 hours of on-site education and mentorship. So you want somebody to look and to see and to be over your shoulder, just like in dental school and hygiene school, somebody was over your shoulder as you were working with clients and patients. Yeah, that's going to be me over your shoulder, looking and saying, okay, here's where you could do better with your evaluation, not in front of the patient. Clearly, I'm not going to do that, but I can help you to refine how you are working. Okay. So is my face in the way? My face is totally in the way. Through 222, 223 is really what it got set to. But through the rest of this week, you could save $500 off the myopathway course with this code TMC, which really stands for the Myo community, but TMC 500. $500 off the myopathway course. I have actually never offered that before, $500 off of the course. And again, this is a course where you don't pay any extra and I come to you. You get 6 hours, 6 months, 6 months of one-on-one, like you get to ask questions and so forth. So be confident in the courses that you're choosing and when you're going forward, when you're talking to patients about things, super confident. Okay. I hope that this has been very valuable for you and that you've learned something along the way. If you have learned something, I'm so honored to have been the person to have given you a little gleam of inspiration, hope, understanding, or something. If you have any questions, leave them in the comments. I actually have patients I have to go see now, so I'm going to run. But I will come back and I'll check all the comments, and I wish you all the very best of evenings. God bless everyone. Have a great night.